So my screen is visible?
Yes, sir.
Yes, sir. Yes, sir.
Okay. So, the back pain has been many times described in the textbook as a mystery. The mystery which can't be solved. There are lots of factors, unknown factors, and the psychological factors, social factors, what not. And if you are going into the textbook, what was written in the 90s, even in the early this century, you'll see that it has been written that the more than the 80% cases, the cause and the exact mechanism and the exact source of the pain we are not able to understand. So this was the scenario earlier, but now it has changed a lot. So this was past. Mysteries in the back pain diagnosis. More than 80% situation had no specific diagnosis, but present the situation is different. Here now, 80% situations we can make a diagnosis, and the future we have to make it 100%. So, what is very important? It's a very important concept which actually changed. Why there this change? Earlier you used to tell 80% we don't know. Now you are telling yes, 80% we know what are the causes. So, which inventions, what discoveries basically was able to make this radical change? And this is by the concept of pain generated. So, to be a source of pain, some structure must be having a nerve, a nociceptive nerve. If there is no nerve, that structure cannot be a source of pain. And if you are giving local anesthetic into that nerve, supplying that particular structure, what should happen? The pain should be reduced or completely, vanished. So this is how we can identify a pain generator. So in the late 90s, there was, very important milestone on important study. So what was done there? So in that study, what was done? They collected all these patients where the spine doctors, whether it's an orthopedic surgeon or the neurologist, pain physicians, whatever it might be, where the diagnosis was not known either by clinical examinations or by image or by everything diagnosis. They have collected those patients, and what they did, they injected local anesthetic into the suspected structure. So what in our back, there are a lot of structures which is having the nociceptive nerve, like a facet joint, like a sacroiliac joint, like a, the nerve root, like a, the many other structures. So what they did, they injected local anesthetic into the most suspected structure. If no pain relief, then the next suspected structure. In that way, they tried to find out what can be the source of pain. Remember, they have the inclusion criteria of this study was what? That no diagnosis was possible by clinical examinations and by image. So now, in this study, so the inclusion criteria, what I told is, where the no diagnosis was not possible. So now, in this inclusion, in this group of patients, what was done? Local anesthetic injection was given one by one. And what was the finding? Finding was in 13% situations, still no cause was identified, but in 87% situation, the exact source of the pain was identified. So this was one of the very important, very important milestone in the history of the pain management. So after that, there is a lot of such studies, and by which we are now knowing that exactly what are the structures which can be source of the pain. So we'll be discussing it later, that these are the structures: facet joints, sacroiliac joint, lot of muscles, the quadratus lumborum, the psoas, then your, amongst the joint there is a hip joint, and apart from that, all the spinal canal structures like nerve root, the spinal, the dura, and then anterior to the spinal canal, the vertebral body, the disc. So all this can be a source of pain. So now, if we are having a list of these pain generators in the back, which can be a source of pain. So number one is the disc. Number one is your disc, facet joint, sacroiliac joint, different skeletal muscles, ligaments, vertebral body, some bursas are there, so hip joint. So all these structures can be responsible for the back. So now in this, the next subsequent slides, so I'll be going through the each of these. I'll not be able to go into the detail of that because we have to restrict our lot of important informations in this 12, 13 module. So that is the reason why I'll not be able to explain very details of it. What I'll be asking you, please all of you subscribe the Dorodia Pain Clinic YouTube channel. So all these lectures are there. So these are all free lectures are there. So please go through those lectures, and you can get a lot of things regarding all those individual structures. So those lectures, please find it out by searching, and you can go into the detail of that. So in this lecture, because of the lack of the time, I'll be just covering the salient points, but not the details of each of these structures, because each of these structures takes at least 1.5 hours to explain the details of the disc or facet joint or SI joint. So I'll be just mentioning the salient points, and I'll be asking you to go through the detail. Particularly, I'll be asking you to go to the YouTube channel lectures, and you can learn the details of it. So when we're talking about the pain generators, initially the initial study that I mentioned in 1998 was the local anesthetic injection to find out the source of the pain. But another very important part we have to understand, that only source of the pain is not enough. We have to understand why question also. So where question is means where is the source of the nociceptor? But second question is why that anatomical structure has been converted into a nociceptor. Why? So that means suppose facet joint is the source of the pain, we could understand by injecting the local anesthetic. But the second part of the question is why a facet joint has been converted into a pain generator. A normal facet joint should not produce pain. So what is the abnormality? So why is very important part. So most commonly the why answer is either degenerations or inflammatory disease like spondyloarthritis or malignancy or trauma or rarely infections. So all these questions should also be answered. So to find out the pain generator, two important parts. One is from where the pain is coming, and second is why that anatomical structure is converted into pain generator. So I'll be just discussing the 8 important structures, whatever I told. I'll be just briefly discuss about all those things. So first, let us start with disc. So if disc is a pain generator, then what are the different pathologies which can convert a disc, normal healthy disc, into a painful disc, and how this can be presented clinically? So these are the 3 important that I mentioned here. 3 important pathological conditions. One is your internal disc disruption, one is your disc collapse, another is your canal stenosis. These are the 3 important, very common disc pathologies, so which can be presented, and the disc itself is a source of the pain. So now I'll be just briefly describing a little bit about the disc, its structures, its nerve supply, and when it is presented as a how they are presented clinically. So just for the recapitulation, that disc has 3 important structures. 2 we can see here. One is annulus. Somebody's microphone is not muted, please. Some noise is coming, please mute. Okay, I muted it. So the disc has 3 important structures. 2 we can see. One is your annulus, second one is nucleus. Third we cannot see in this cross section, that is in the above and below. It's like the sandwich. Above one end plate, cartilaginous end plate, and below one end plate. So in this nucleus and the annulus fibrosus, the annulus fibrosus is a tough cartilaginous layer, and it is all around. There are several layers, 15 to 25 layers, and in the nucleus pulposus there is a soft gel-like thing. Nucleus pulposus is basically responsible for giving the flexibility or the pliability of the spine, whereas annulus fibrosus main function is giving the height of the disc. So the disc height, if it is not maintained, there are a lot of other important, the sequelae or important things happens if the disc height is not maintained. So disc height is maintained by the annulus fibrosus, and it is also holding the nucleus pulposus. It is not allowing the nucleus pulposus to leak because of the tough layers of the annulus fibrosus. Another important function of the annulus fibrosus is that outer one-third of, this is again very important, outer one-third of the annulus have the blood vessels and the nerve supply. Inner two-thirds of the annulus and whole of the nucleus pulposus, there is no blood vessels, no nerves. That means if you are cutting something from the normal healthy, the nucleus pulposus, patient will not feel pain because there is no nerves inside. So inner two-thirds of the annulus and whole of the nucleus pulposus, there is no blood vessels, there is no nerves. So how the nutrition of the disc is maintained? Answer is by the diffusion. Outer one-third have the blood vessels. So by diffusions, these nutrients are going inside and supplied and feeding there are chondrocyte cells are there inside the nucleus pulposus. So these chondrocyte cells need oxygen, needs the nutrients, and how they are going there? By the diffusion from the periphery. So again, one of the very important concept which has been a radical change from the earlier concept is, earlier used to see, you have seen that somebody is having the back pain. What is the advice by a doctor? Lie like a log of wood for next 3 weeks. Don't move even, don't sit, don't stand. But nowadays, this recommendation has changed. Nowadays, recommendation is don't lie down for more than 2-3 days. There are lots of other complications of the lying like a log of wood. Don't do that. So one of the very important thing is, another important, the recommendation earlier was sit like a straight with a ergonomically designed chair, and that is the best sitting posture. But nowadays that also have been changed. So what is the best sitting posture? Best sitting posture is changing posture. So sometimes you sit like this straight, sometimes you sit like this. So that is the best sitting posture, means go on changing a posture. Don't sit in a same posture. So now why? So you'll be able to understand why. So now what I told, that the oxygen and the nutrients are actually diffused internally to supply the cells inside the nucleus pulposus, because there is no direct blood vessels, and this diffusion is dependent on the fluctuation of the interdiscal pressure. So if the disc pressure is remaining constant, then what will happen? Then the nutrients will not be diffusing nicely. So these cells inside will be suffering from the degenerative changes early. That means if you are forcing somebody to sit, lie like log food, what will happen? All the time his or her interdiscal pressure will be very low. When you're lying down, our interdiscal pressure is very low. When you're sitting, our interdiscal pressure is high, very high. When you stand, interdiscal pressure is in between sitting to standing. So all this is very important. When you're sitting like this, interdiscal pressure is higher. When you're sitting like this, interdiscal pressure is little less. So this fluctuation of the interdiscal pressure, high, low, this is important. And that is the reason why bed rest is not good. That is the reason why sitting on the same posture for the long time is also not good, because diffusion of the nutrients and the oxygens will be affected. So this is one of the very important concern. Another important part, how do you need to know, is the nerve supply. As you told, that the outer layer of the annulus have the nerve supply, and the whole of the nucleus pulposus and the inner layers of the annulus don't have the nerve supply. So question is, if there is any nociceptive pathologies inside, so the person might not be feeling any pain. But when there is degeneration of the disc, so there are certain changes. So what will happen if there is degeneration of the disc? Degeneration always starts from the inner layer of the annulus. So if the disc inner layer of, so remember, degeneration of the disc means the degeneration of the inner layer of the annulus. It's a rule. Nucleus pulposus is not affected by the degenerative process. So degenerative process starts with the inner layer of the annulus. So if the inner layer is degenerated, what will happen? It will be weakened. So if it is weak, what will happen? The nuclear material will start leaking, because it is a tough structure. So it is holding the nucleus pulposus. So now it is degenerated. So now it starts leaking. So if it starts leaking, body what will do? body will try to repair it. And how to repair it? By sending more nutrients. How to send more nutrients? Because it don't have the blood vessels. So there should be neovascularization. So now the blood vessels will be growing to supply the nutrients and the essential materials for the repair. So when the blood vessels grows in, the sympathetic nerves, the nerves which is there in the outer layer of the annulus is sympathetic nerves. The sympathetic nerves will also grow in. And then what will happen? They will be meeting. The blood vessels, the nerves, and the nuclear material will be meeting. And this meeting is not a pleasant meeting. Why? Because our nuclear material inside is segregated from the body's blood vessels, immune system since fetal life. So when the first time is meeting, the body's immune system will think the nuclear material what is there? There are lots of glycoproteins are there. So these glycoproteins helps to increase the osmolality and to hold the water. So this glycoprotein, when they will be coming first time, the most abundant glycoprotein is your aggrecan. So this aggrecan glycoprotein, when they will come first time in the body's immune system, body will think that it is a foreign material. So what will happen? There will be strong chemical reaction, inflammatory reaction. And this inflammatory reaction will also affect the sympathetic nerve which is growing in. So the sympathetic nerve is now getting inflamed and now they are getting sensitized. So earlier, if your interdiscal pressure is going high, like as I told just now, when you're sitting, our interdiscal pressure is high, very high. Now, when you are standing, it is little less. When you're lying down, interdiscal pressure is less. So remember these three important postures: lying down, less interdiscal pressure; standing, more interdiscal pressure; sitting, maximum. And if you're sitting bending forward, then the interdiscal pressure goes highest. So now, if somebody is having this problem, means nuclear material has started leaking, the blood vessels and nerves has grown in, there is inflammatory reactions within the annulus, the inflammation is spreading amongst the sympathetic nerves. So now the sympathetic nerves are getting inflamed, sensitized. So now what will happen? Any little fluctuation of the interdiscal pressure is going to produce pain in this sympathetic nerve. Okay, and this condition is called internal disc disruption. Remember, it is not prolapse disc. This is called internal disc disruption. Internal disc disruption. So here, where will be the pain? How will be the pain? So here the nerve root is not affected. Why nerve root is not affected? Why it is called internal disc disruption? Because everything is happening internally. So leakage of the nuclear material. Radiologically, this is also called annular tear. So some of the annulus has torn, the nuclear material has leaked in within the layers of the annulus, sympathetic nerves has grown in, sympathetic nerves are inflamed, and that is producing pain. So this is called internal disc disruption, because externally, if you're looking at the disc, everything is nice. The nerve roots are fine. There is no pressure or inflammation of the nerve roots, just posterior. So here the patient will present with back pain, only diffuse back pain, not sharply localized back pain. Why? Because it is sympathetically mediated pain. The pain mediated by the sympathetic nerve, because sympathetic nerve is non-dermatomal. So because it is non-dermatomal, so sympathetically mediated pain will be diffuse. It's not localized. Whereas somatic nerve mediated pain is sharply localized. So here the pain will be diffuse back pain, no leg pain because the nerve root are not involved. And this back pain is aggravated on sitting. Why sitting aggravated pain? Just now I mentioned, sitting increases the interdiscal pressure is highest. Bending forward, sitting will be increasing the pain maximum. Standing, pain will be little reduced, but not completely reduced. If you're lying down, then the interdiscal pressure will be going very low and the pain will be reduced or relieved. On walking, what will happen? Pain will be little less than sitting, but there will be no radiating leg pain. Or even if there is some radiation, some vague radiation might be there around the buttock, around the posterior skeletal thigh, sometimes this radiation is same, but never beyond the knee, very rarely beyond the knee. So this is a non-dermatomal radiation pattern in the back of the thigh, is seen sometimes in some patients, but mostly the patient will not be having any radiation pain. Mostly it is diffuse back pain over the whole of the back, which is aggravated on sitting. Which age group is most commonly affected? Mostly the 30s. Why 30s? Because when we grow older, our nuclear material has less fluid. Why less fluid? Because the chondrocyte molecules which are actually producing this glycoprotein molecule, just now I told this glycoprotein molecule like aggrecan, they are responsible for increasing the osmolality. So how much water will be there within the nucleus pulposus depends on two factors. One of them is how much is the osmolality and how much is the interdiscal pressure. So the interdiscal pressure, it's like I give the example of how whether the blood will be fluid will be there in the capillary or it will be going to the outside the capillary to produce edema. Depends on how much is the blood's osmolality. Like if there is a hypoproteinemia, what will happen? The oncotic pressure of the blood will be less and water will be diffused outside the capillaries. Same thing happen here. If the glycoprotein molecule number is less, then the water will be diffusing out because of the interdiscal pressure will be going higher than that of the osmotic pressure. And that happens in the elderly person. The elderly person, if you are having an MRI, you will see all the disc is dehydrated, black. This is not a pathological condition. This is called aging of the disc. So here the water content of the nucleus is much less, but otherwise it is not a painful disc, because water content less means disc will be the spine will be less pliable, less movable, but it is not going to produce any pain. So when we are growing older, then naturally there will be less water content. This is called aging of the disc. So aging of the disc affects nucleus pulposus, whereas degeneration of the disc affects inner layer of annulus. So coming back to the internal disc disruption. So internal disc disruption patient will present with predominant diffuse back pain, poorly localized back pain, no radiation pain to the leg. Even if there is some radiation, that is non-dermatomal radiation, because nerve roots are not affected. The disc looks everything fine from outside. And sitting aggravates the pain, standing relieves a little bit, walking do not aggravate the pain much, lying down relieves the pain completely. Patient is younger because you need to have the fluid. Unless the fluid is there, it will not be leaking. So you will not see the internal disc disruption because the disc is already dehydrated. It will not be having a tendency to leak. So this is a 30s. Typically a patient will be telling, I am a computer, IT professional, whole day I sit in the chair and doing on the computer work. I very rarely change my posture, sitting constantly for the same posture, and that is going to invite the disc degeneration, and inner layer is leaked, nuclear material is leaked, and all the things whatever I explained right now is happening. So this is your internal disc disruption. It presents with back pain, not the leg pain. And remember, this is the commonest cause of back. Now, second important disc pathology is, so if the disc is a pain generator, so how they can present? This is what I'm trying to explain. So first way of presentation, first type of pathology, disc pathology, is your internal disc disruption. Second is your disc prolapse. So disc prolapse, what is happening? So this nuclear material is still going out, and then it is leaking and involving the. If it is leaked here, there will be no problem because no important neural structures here. But if it is leaking posteriorly or posterolaterally, then this is posterior side. So then what will happen? Nerve root will be involved. So if the nerve root is involved, so inflammation, what I was telling, because the nuclear material is segregated from the body's immune system. So when it first comes, that will be causing the inflammation. So inflammation of the nerve root also. So this inflammation of the nerve root will produce pain in the leg. I'm talking about the back, lumbar area. So this nerve root is going to supply the leg. So there will be leg pain. And this leg pain will be dermatomally distributed. So this patient will be having a vague back pain, but predominant leg pain. Predominant leg pain which is dermatomally distributed along the nerve root. So if the L5 nerve root is involved, it will go up to the great toe. If S1, L5 and S1 is the most commonly involved. If S1, it will go to the lateral arch to the foot, up to the little peep toe. So if it is L4, then it will go up to the medial malleolus, front of the leg and medial malleolus. So you need to learn the dermatome as well. So, and that was, you can tell that which nerve root is getting involved. So disc prolapse and internal disc disruption, what are the difference? Internal disc disruption presents with predominant vague diffuse back pain. Vague means vague in localization, not mild. Sometimes pain is very severe, but vague in localization, poor in localization. Why? Because that nerve was, this nerve within the outer layer of this was the sympathetic nerve. But this nerve is your somatic nerve. So here the pain is sharply localized in the leg along the dermal. So this is your prolapsed disc. So here walking will be aggravating the pain. Straight leg rising test will be positive. What you are doing straight leg rising, if you are lifting the leg, you are stretching the nerve root. So stretching the nerve root will be making the the pain, aggravation of the pain. And the third kind of thing is your canal stenosis. So central canal, you see, again, this is a very important concept, so listen very carefully. So this is the central canal, spinal canal. So what is the boundary? Posteriorly there is lamina, and in between the two lamina, what is there? Ligamentum flavum. So posterior boundary of the central spinal canal is your lamina and ligamentum flavum. Anterior boundary is your posterior wall layers of the annulus. Posterolaterally, there are the facet joints. Here is the facet joints, and laterally it is open at the neural foramen. So this is your boundary of the spinal canal. So now, mostly the canal stenosis starts with disc pathology. So what will happen? Suppose here the significant portion of the annulus is getting degenerated. So what will happen? One of the very important function of the annulus was what? Giving the disc height. So if the disc height is not maintained, what will happen? The two vertebral body will come closer and the disc will be bulged, posteriorly. So if it is bulging posteriorly, because it cannot stand, it is bulging. So what will happen? The canal will be compromised by the anteriorly by the bulging disc. So now, immediately when the two vertebral bodies are coming closer, the lamina is also coming closer. The two lamina is coming closer. In between the lamina is ligamentum flavum. Ligamentum flavum is like a ligament, so it will like a curtain, so it will be folded. So ligamentum flavum will be folded from posteriorly, so that is going to compromise the canal from the posteriorly. So it is called ligamentum flavum hypertrophy. So hypertrophy is a misnomer. Basically, it is the folded ligamentum flavum. Why folded ligamentum flavum? Because the two vertebral bodies are coming closer. Two lamina are coming closer. So the ligamentum flavum in between the two lamina, they are getting folded, and that is going anteriorly. So that is going to compromise the canal from posterior. And facet joint hypertrophy many times is associated, that is contributing from posterior laterally. So canal will be compromised. So now this is a chronic condition. So if this canal is compromised chronically over the period of time, what will happen? Which structures will be affected first? First, it will be affecting the blood vessels. Later on, the nerves. So if the blood vessels is compromised, so initially blood circulation to the nerve, to the spinal cord will be less. Now, when we are sitting, what is happening? Our nerves needs less oxygen supply. But when you are standing, 2-3 things happens. When you sit, normally what happens? We flex forward. If you flex forward, what will happen? The ligamentum flavum will be stressed. Because you remember, you understand, try to understand that when you are flexing spine forward, the ligament, the two lamina will be stressed and the ligamentum flavum will be stressed. So the posterior component of the the canal stenosis will be relieved because two lamina is separated, ligamentum flavum is stressed, and the folded ligamentum flavum is no longer there. So the posterior component will be corrected. So flexing increases the canal diameter. So when you're sitting, patient don't have any symptoms. Why? Because of two reasons. One is nerve needs less oxygen because it is not working. And second, sitting increases the canal diameter. So this canal stenosis patient is very comfortable on sitting. You understand why? Number one is the nerves needs less oxygen. And number two, because sitting is flexion, so flexion separates the two lamina. Separation of the two lamina means stretching of the ligamentum flavum. So the folded ligamentum flavum is no longer there. So what will happen? The canal diameter will be increasing. So finally, no symptoms. So now these patients, when standing, what will happen? The ligamentum flavum is now folded, pushing the dura. So patient will be having the back pain. And Now the nerve needs more oxygen, particularly when the patients are walking, and that oxygen demand will not be fulfilled because the blood vessels are partially compromised by the less canal diameter. So what will happen? There will be ischemia of this nerve on walking. So the patient will be having pain in the leg. This pain will be some neurogenic component will be there, some tingling sensation, some heaviness, some numbness, because this is ischemia of the nerve. It is not the ischemia of the muscles and bones. So ischemia of the nerves will be there, and this is called neurogenic claudication. So the neurogenic claudication is one of the very important feature of the spinal canal stenosis. So sitting, no symptoms; standing, there is back pain; walking, there is neurogenic pain of the leg. So now if this patient is sitting, the canal diameter will be increasing and the pain will be relieved. And if there is no place to sit, this patient normally flex forward, leaning forward, stooping forward. Stooping forward will be flexing the spine and the ligament applied is stressed, canal diameter will be increased and symptoms will be relieved. So this, elderly populations many times in the, in the shopping mall, this is also called, shopping cart symptom, because shopping cart, when they are pushing it, they normally lean forward. So that will be increasing the canal diameter. So these are all features of the spinal canal stenosis. And if this goes on, what will happen? There might be nerve damage as well. So permanent nerve damage is also seen in the canal stenosis. So lumbar canal stenosis, central canal stenosis, lumbar spinal stenosis, all these are the nomenclature. So normally, what is the diameter of the anteroposterior diameter of the spinal canal? This diameter is more than 13 millimeter. More than 13 millimeter, 15, 17, 18, even up to 20. But when it is less than 10 millimeter, this is called absolute spinal canal stenosis. And if it is in between the 10 to 13, then it is called relative spinal canal stenosis. So the spinal canal stenosis you understood. So disc, three types of disc pathology. Let me repeat again. One is your internal disc distortion, small leakage within the layers of the annulus, blood vessels and nerves will grow in. This patient presents with back pain, diffuse back pain, sympathetically mediated back pain. Next, it is leaking further, compressing the nerve root. They present as a radicular leg pain. Back pain will be less here. Radicular leg pain, which is increasing on walking. And third, spinal canal stenosis. Sitting comfortable, standing produces back pain, walking causes the neurogenic claudication, and that is your presentation of spinal canal stenosis. So remember, there are the three different kinds of disc pathology. So when the disc is a pain generator, it can present in a three different way depending upon the question of why. Why the disc? There are the three different kind of pathology, and they can present in a three different way. So normally internal disc disruption and disc collapse, they need a fluid nucleus pulposus. That means internal disc disruption and disc collapse are the problems of the younger, means 20s, 30s, 40s, 50s. But when the people goes into 60s, 70s, 80s, then the first two is less common, and canal stenosis is more common. Right? So remember, disc is very, very important. Next is your clinical features. Internal disc disruption or degenerative disc is your back pain, which is increasing on sitting. Next is your disc collapse, but the leg pain is relieved on sitting, on lying, increased on standing. On the, please mute.
Dr. Pratiksha, please mute yourself.
Okay, so internal disc disruption.
I think sir has got disconnected, so just wait. Devjyoti boss, we can't hear you. Okay, sir is back.
Am I visible now?
Yes, sir. But you need to share your PPT again. Okay, sir got stuck up again. Devjyoti boss, are you talking something? We can't hear you. Sir, you are also muted.
Okay, is it fine now?
Yeah. Great, sir.
Okay. So I'm sorry, actually, sometimes internet connection, I was connected with one net, now I am using the second one. Okay, so I was discussing where I was discussing about the disk, probably here. Can you see my screen now?
Yes, sir, we can see.
Okay, so I was discussing about this thing, that how the disk can be presenting. So now the next one, so confirmation, how to confirm the diagnosis. If the disk pathology, if you are in your provisional diagnosis, always think of MRI, EMG, and CB. So these things should be done. And sometimes dynamic communications block can also be done. Sometimes selective nerve root block can also be done. But mostly you have to remember, MRI is the investigation of choice whenever you are suspecting a disk pathology. Now important is your facet joint. If the facet joint is a pain generator, so how this patient will present? Normally these patients are elderly because degenerative pathology is the most common. Even if it is inflammatory, then the clinical features are almost same. It can be mostly, as I told, degeneration, inflammation, trauma, malignancy. They are the less common causes. So facet joint is forming the posterolateral boundary, as I also already mentioned. So now, how to load facet joint? If your extension, lateral bending, and rotation, they are the three movements when the facet joint is loaded maximum. And how to unload the facet joint? Flexing forward. So when you are sitting, we are flexing the spine, so facet joint is unloaded. And that is the reason why in facet pain, patient feels comfortable on sitting. So pain is reduced on sitting if it is purely facet joint pain. So how the patient will present? Predominant back pain. Facet joint is supplied by the medial nerve, which is a somatic nerve, not a sympathetic nerve. So pain will be sharply localized. It normally don't have any radiation, but even if it is a radiation in the back of the thigh, it is normally non-dermatomal radiation. Disc prolapse pain radiation was dermatomal, but in other conditions, it is a non-dermatomal radiation. So facet joint pain also will be having a non-dermatomal leg pain. Pain is relieved on sitting and on bending forward. Why? Because facet joint is unloaded. Pain is increased on extension, lateral bending, and rotation. Pain is decreased on walking. Why? Again, you have to remember the joint pain normally aggravates on after rest. After rest, if you're moving, joint pain will be increased. But after certain movements, pain will be gradually relieved. And there will be no neurodeficits. Like in the disc prolapse, like in the canal stenosis, we told that there might be the nerve damage and there might be the neurodeficits. But in facet pain, pure facet pain, there will be no neurodeficits. So they are the clinical features. And final confirmation should be done by a diagnostic medial branch block. Image MRI has less value in making a diagnosis. So confirmation of the diagnosis by medial branch block. Next is your sacroiliac joint. Sacroiliac joint is also supplied by the somatic nerve. So here also the pain will be sharply localized. Why it can be a pain generator? It can be because of the degeneration, inflammations, malignancy, trauma, all this can be. But again, most common is your degeneration. Next common is your inflammation. How this patient will present? they'll present as a buttock pain at the lower back pain, which is well localized. And there might be again like facet joint, like internal disc disruption. There might be a non-dermatomal leg pain in the back of the leg. Pain increases on sitting. Why? Because sitting loads sacroiliac joint and relieved on standing or walking or lying down. And again, there'll be no neurodeficits. So this is how a SI joint pain presents. How to confirm the diagnosis? By diagnostic SI joint injection. So some of these procedures will be shown today by on the CM. Then next is your muscles. There are several kinds of myofascial pain, as I already mentioned, like quadratus, like psoas, like your piriformis. There are three important muscles. You know, there are a few other muscles also. So where there can be a myofascial pain syndrome. So there the etiologies why a muscle can be a source of pain. Normal muscle is not a source of pain. So the other reasons. Then how to confirm the diagnosis? By trigger point injection. If you're giving trigger point injection, pain should be relieved. Then some ligaments are also there, particularly, there is interspinous ligament. So these ligaments, when they are source of the pain, the sprain or the inflammations, so we can confirm the diagnosis by local anesthetic injection. Then vertebral body fracture or malignant tissue infiltration in the vertebral body can make a normal vertebral body into a painful vertebral body. So trauma and malignancy, fracture. So the other causes. Again, how to confirm? One is definitely by MRI, but sometimes one of the very important thing is your diagnostic Raman communicant. So Raman communicants is the nerve fibers which takes the nociceptions from the vertebral body and the disc. Sympathetic nerves which is there around the disc and the vertebral body. Finally, through the Raman communicants fibers, they enter into the spinal cord. So if you are giving a diagnostic Raman communicants block, you can understand whether a fracture is really painful or not. Many times old fracture is thin, which may not be painful. By clinical test, if you can confirm it, it's fine. Otherwise, you can go for the diagnostic Raman communicants block. Some bursas are there, particularly the greater trochanteric bursas and some other bursas which can be a source of the pain. Again, how to confirm? By local anesthetic injection. Hip joint itself, hip joint pathologies, again can be a cause of, and many times it is missed. Most of the times you're concentrating on the facet, SI, and many times you miss the hip joint. Even I have seen the hip fracture is the cause of the pain and unable to stand. And it was diagnosed as a prolapsed disc because MRI was showing something, asymptomatic changes. And the patient was very simple, hip fracture, neck femur fracture. So that diagnosis was missed. I have seen this kind of patient. So remember, the hip is also one of the very important, should be coming in the differential diagnosis of the back pain, low back pain. So how to confirm? If you have any doubts, fracture confirmation is easy, but sometimes the other structure confirmation is not that easy. You can do a diagnostic intra-articular hip joint injection guided by ultrasound or stem, and that can confirm your diagnosis. So in the first, again, I'm coming to my conclusion slide. So earlier the mysteries was more than 80%. We are talking that we cannot make a diagnosis, non-specific back pain, the mechanical back pain, the other terms. Nowadays, more than 80% we can make a diagnosis. But in the future, we have to answer for the diagnostic interventions where there is a false positive results, where there will be sensitization, somatization. So all these things should be coming into considerations. So they might be responsible for the remaining 15 to 20% of the cases, which also need to be solved. So this should be, will be coming, some things will be coming in the future. So if you are having any, sorry, this was an old slide. So if you have any questions, you can ask me. And before going to the next part, means that some of the procedures will be demonstrated on the mannequin under the CM guidance.
Sir, there is one question for you in the chat.
Yes.
By Dr. Manish. Is the canal diameter same throughout vertebral column? Like when we say that the canal diameter is less and clinically significant?
You see, there is no canal diameter, though we told that theoretically it is less than 10 millimeter, but more than diameter of the canal, more important is your clinical features. That means whether the patient is having the clinical features of the canal stenosis. I normally tell one story. So just a brief story because of the lack of the time. So I have seen canal diameter 4 millimeter, 5 millimeter without any symptoms. So answer is whether there should be, we should do anything. Answer is no. So canal diameter is just to understand, to have an idea about what is the normal canal diameter, what should be the, but we have to remember that, that clinical features is more important. And nowadays, more than canal diameter, more important is the cross-sectional area, which actually correlates more with the clinical features. Cross-sectional areas, 72 square millimeter is the areas which is normally, significant. But again, the direct relationship is not there. So always remember that the clinical features like history of your neurogenic claudication, any neurological deficits, these are more important to make a diagnosis of the canal stenosis rather than the canal diameter or the cross-sectional areas. Okay, any more questions coming in the chat box?
Many questions, sir.
Okay, you just ask me. I cannot go through the chat.
No, I'm doing it. Don't worry, please. Dr. Sujana wants to know what is medial branch block. I think we'll be demonstrating, so that
it will be demonstrated on the mannequin.
Getting her answer. Dr. Anindam wants to know, in canal stenosis specifically, which nervous structure causes ischemic pain?
As I told you, all the contents of the spinal canal, that means your chordae equina fibers, depending on where it is. If it is a lumbar canal stenosis, that means all the chordae equina fibers, at that particular level, whatever the nerve roots is hanging there in the fluid, all might be ischemic. Depending on I have not gone into all the details because again lack of time. So it is canal stenosis is normally divided into central canal stenosis and the lateral canal stenosis. Lateral canal stenosis means where the neural foramen is starting. So in the lateral canal stenosis, normally the exiting nerve root is what is getting involved, or sometimes traversing nerve root is getting involved. That ischemia of that particular nerve causes the pain. But if it is a central canal stenosis, all the nerve root which is passing that level might be ischemic. Okay.
So Dr. Ronald, I'm sorry for the wrong pronunciation. He wants to know, are there any clinical tests to confirm sacroiliitis?
There are lots of clinical tests. Again, because of the lack of time, most commonly done clinical test is your Fipm test. That Fipm means, or it is also called Patrick test, means flexion, abduction, external rotation. So the patient will be lying down supine, and that Fipm test would be putting pressure on the SI joint, and it will be positive. But there are a few other Glenson's tests, sacral thrust tests, so a lot of clinical tests are there. So please go through the literature, because a lot of other clinical tests are there. So if I'm going, so back pain itself might be taking 3-4 more lectures. So please, I'll be telling you another thing. Please go to our YouTube channel, as I told you at the beginning, and all these clinical tests and everything is there. You can go through all those things. So a lot of clinical tests are there for the sacroiliac joint pathology, sacroiliac joint pain.
So Dr. Pooja wants to know why internal disruption in early 30s, how prolonged sitting causes degeneration of annulus fibrosis.
Exactly how much of prolonged sitting is, it varies from person to person. If you are asking somebody have the baldness at the 30s and somebody is having full of hair at the 80s, why, we really don't know. That means some patients, why they are prone to develop the internal disc disruption in the younger age, we really don't know. But the things which might be responsible is your prolonged sitting, degeneration of the disc, it means inner layer of the disc, all those things. But as I told you, it is more predominantly seen in the younger. Why? Because in the younger, the fluid content of the nucleus pulposus is much more. So more tendencies for this nucleus pulposus to leak, and that is the reason why it is more commonly seen in the younger population. But exactly how long sitting is important, we cannot tell like that. But what we have to remember, what normally we advise to the patient, don't sit for more than half an hour in the same posture. At least, you stand or sit like this, all those change of posture is always important. Don't sit for more than half an hour. But again, there is no specific rule that this much of sitting is going to produce your internal disc disruption.
I think Dr. Monica, you also have the same question, so you might have got your answer. So Dr. Farhad wants to know, how do you treat internal disc disruption?
Treatment part I have not discussed here. Just remember that the internal disc disruption, the best, the treatment is nowadays the most evidence based is your biacuplasty. It's a kind of bipolar cooled radio frequency. But on the another very simple thing is your caudal epidural. Caudal epidural also gives very good results, but short-term results.
Okay, so Dr. Divyansh wants to know, can we clinically distinguish the different pain generators in overlap pain syndromes?
Clinically, we can have some idea, but confirmation must be done by the investigation. So investigation, one of them is your MRI, but MRI is not enough because MRI might be having a lot of asymptomatic changes. So final and the best confirmation is by your diagnostic intervention. As I told you at the beginning, that MRI and other image make the mystery lives behind in more than 80% situation. So final confirmation should be done by your local anesthetic injection. I have mentioned all the pain generators. The best way to confirm is your local anesthetic injections. But before that, you must be having a screening image. You must be having an image and having some short listing of the diagnosis. And then finally, you go for the diagnostic interventions to confirm your diagnosis.
Dr. Arindam wants to know post-menopausal low back pain.
Post-menopausal low back pain is again a vague term. We don't know this kind of things. You just tell that, okay, I just told what are the most common pain generators. So is a facet, SI, all those things. Only thing what you can tell is your osteoporosis is more common in the post-menopausal women. But osteoporosis and the pain directly don't have any direct correlation. Osteoporosis do not produce, remember this words, again I'm repeating, osteoporosis do not produce any pain unless there is a fracture. Osteoporosis increases the risks of the fracture, but osteoporosis itself do not produce any pain. So the post-menopausal pain is really a vague term. You have to find out where is the pain generator, and you have to plan your treatment accordingly.
Dr. Prasanna wants to know, can you repeat internal disruption pathophysiology?
Oh my God, I repeated 3-4 times and I told. Just again, 2-3 lines. So, degeneration starts from the inner layer. So inner layer, if it is regenerated, nucleus pulposus will start leaking. And outer 1/3 of the annulus have the blood vessels and the nerves. So to repair that degenerations, leaking, body will try to supply nutrients. How to supply? By neovascularization. There is no road. I normally tell there is a natural calamity. So the military will, immediately starts building the roads. So to supply the, the nutrients. So their neovascularization, nutrients are going, but at the same time, because the sympathetic nerves are there along with the blood vessels, sympathetic nerves will also grow. So they'll meet. When they meet, this nuclear material is away from the body's immune system since the fetal life. So first time when they will meet, they'll feel that, okay, these proteins are foreign materials. So there'll be chemical inflammation. And that inflammation will spreading to the sympathetic nerves. So sympathetic nerves, which was not painful earlier, now will become painful because it is inflamed and sensitized. So this is the pathophysiology of your internal disruption. So sitting will be increasing the pain. Why? Because sitting will be increasing the intradiscal pressure, and rise of the intradiscal pressure causes sensitized sympathetic nerve to produce pain.
Dr. Subbulakshmi wants to know, most of the time, both facet joints and disc pathology cause big back pain. How to differentiate or how to proceed for treatment?
As I told you, that clinical test, like if you're doing the extension, rotation, facet joint pain will be produced by history. And so all these things you have to shortlist by MRI and final confirmation by the local anesthetic diagnostic block. Facet joint can be easily diagnosed with a medial branch block. That will be demonstrated right now.
And Dr. Divyansh wants to know, what are the contraindications for local anesthetic injection for screening?
It is general contraindication for the interventional pain management, like if there is a local infection, if there is an uncontrolled blood sugar, if there is a coagulopathy. So these are the general contraindications for any intervention. So these are the contraindications. There is no other. And of course, the lack of consent. If somebody is not interested to do anything, any needle prick you cannot do. So these are the contraindications.
Dr. Gurpreet wants to know, kindly explain the treatment for annular tear.
Annular tear and the internal disc disruption are the same, as I told you. Radiologically, when you see that the nuclear material is leaking within the annulus, within the layer, because of the tear, that is called annular tear. And the clinical presentation, as I already told you, treatment I have not described, but I already mentioned the best form of evidence-based management is your biacuplasty. And other short-term management, the best is your caudal epidural. But before that, also you can start with the simple analgesics. You can start. Many times it is still automatically. So first you should try the conservative management with simple analgesics like paracetamol. Later on, you can think of the caudal epidural, and the best treatment is your biacuplasty.
And Dr. Afroza, you have raised your hand. Do you have any query? You can ask. You can unmute yourself when you ask. You can ask because I do not see any question from your side in the chat. Do you have any question?
Either you can ask us or you can write the questions. Otherwise, you will not be wasting much time because already a lot of things have to be there. At least we should be knowing all those CM guided procedures.
Okay, sir. I think later on we can cover up all the questions. We start with the demonstration and all.
Deputy Chinmay, are you ready? Deputy, are you ready?
Yes, sir, we are ready.
Okay, then start.
Yeah. Actually, before demonstration, I have to tell about something about theory parts. Okay, everyone can see my slide.
Yes, boss, we
Yes,
can
yes,
see your
sir.
slide.
Yes.
Okay, which side? Okay, everyone can see my slide or not? Dr. Kanchan?
Yes, boss, we can see it.
Yes.
Are you able to hear me,
Hello?
boss? Yes, yes, I can hear you well.
I'm not audible.
Boss, I think there is some problem with your speaker.
Dr. Kanchan, I am audible or
Yes.
not?
Yes, we
Yes.
can see
Yes.
you. You can see your slide. Your voice is nicely audible. Please go ahead.
Yes.
Are you able to hear us?
Yes.
Chinmay, boss.
Probably Chinmoy's microphone is not working.
Okay. Yeah, USB. Microphone is okay.
You need to tell, sir.
Hello, hello. Just a minute.
Hello.
Yes,
Hello.
boss, we can hear you.
Okay, fine.
Okay. So, okay. Today we will show, we will demonstrate fluoroanatomy of the lumbar spine. I will talk about fluoroanatomy of lumbar spine, and we will show transforaminal epidural injection and facet injection. SI joint is not for today. So, okay. So, first part, let us see that how a normal spine looks like. Okay. Okay, so let us see that how a normal spine look like. This is our normal spine from AP view and from anteriorly and laterally and posterior view. We can see that there is a curve. This is a normal curve in everyone's normal spine. So there is a lumbar lordosis and cervical lordosis, and this kyphotic area of thoracic spine is normal. Okay, and this is also in the sacrum. This kyphotic area is there. So why this is important? Because here you will understand. Okay, these are the degrees of lordosis and kyphosis. So you will this kyphosis and lordosis, normal kyphosis and lordosis, it is very important in our pain procedures. When we are doing the pain procedures, we need to see the vertebrae in a 90-degree totally perpendicular view. We want to see the vertebrae in a 90-degree angle, at a 90-degree angle. So say a patient is lying here in the lower right corner, you see the skeleton. This skeleton, a person, say a person is lying just prone, and over the skin you will not be able to understand the orientation of the bones. Some bone is due to this normal kyphosis and lordosis, the bones, if you keep your needle at a 90-degree position on your on the skin, that will not be 90-degree for all the bones, because all bones orientations are different. So that is why when we see say this fluoroscope is angled. Okay, why this angulation has been made? Because maybe that this angulation is making some vertebra here as a giving us a 90-degree view. This is not 90-degree to the skin, but we want a 90-degree view to the bones, for the bones inside, which may be at a differently angled position. That we will make you understand under the fluoroscope when we will be showing on the mannequin. But you understand that this is the reason why we need to do angulation while we want to see a vertebra in a 90-degree angle. Okay. Then we can see, we know, I mean, like we will be showing the procedures at the lumbar level. So we know the parts of a vertebra. Okay, this is the vertebral body, and this is the transverse process. This is the pedicle, lamina, and spinous process. And again, these are the articular processes, superior articular process and inferior articular processes. Okay, these articular processes actually form the facet joint. You can see here, so that this is the vertebra, and the lower articular processes will be like this, and upper articular I mean, like this is the lower vertebra's superior articular processes will be like this, and from upper side the inferior articular processes will come and join like this. So this will make the facet joint. So you have to understand that from upper upper vertebra, the inferior facets are always in the medial side. Okay. So that is what I'm showing you here. Okay, so that this is inside, this is the inner side, and the outer side facets are some these articular pillars are superior articular process of the lower vertebra. Every vertebra has superior articular process and inferior articular process. Okay, this is the inferior articular process, and this is the superior articular process. Okay, then most of the procedures are done in this way, that patient is lying prone, and will be seeing in this AP view. Why it is AP view? Because anterior side, from anterior. Dr. Bikash, please mute yourself. Okay. Why it is anterior view? Because patient is lying prone, and your image, I mean, like X-ray emitter is under the bed. So from anterior side, this is the receiver. Okay. So from anterior side to posterior side, the X-ray is going. So it is giving the AP view. So most of the lumbar procedures are doing, we do in this position. Okay. Patient is lying prone, and we will see in AP view. So what do you see? So you see, this is a AP view of lumbar spine. So as I said that, okay, main thing is that our spine is a three-dimensional structure. When we see in the X-ray, this becomes a two-dimensional structure. But while looking at it, while you are going to do a procedure, so while looking at it, you have to see this three-dimensional, two-dimensional picture as a three-dimensional picture in your head. Okay, you have to understand that what you are actually seeing. So as I said that this is the facet joint. Okay, this is the facet joint. So lower vertebra will have superior articular process, upper vertebra has the inferior articular process, and facet joint is like this. Okay, so here we see, so these are the facet joints, these are the facet joints. Just Okay. So here you can see. Oh, okay. Okay. Anyway, hmm. so this part is the facet joint. As I said, so lateral side is the superior articular process of the lower vertebra. Okay, this is the facet joint. So here we can see one articular process. This is the another articular process. So medial side articular process is from the upper vertebra, and this is the inferior articular process, and outer side articular process from the lower vertebra, and this is the superior articular process. Of course, we understand that this is the from one vertebra, this is going up, so it is named as superior. This is going down, so it is named as inferior. So there are two articular processes you have understood. And as we know, articular processor, this is the facet joint, and if we see, so this is a much posterior, this is the anterior vertebrae, and these are the posterior articular processes. Okay, these are much posterior, but while we are seeing in a two-dimensional picture, it looks like that it is I mean, like one above the one above other. So you have to understand that which one is the anterior structure and which one is the posterior structure. So these square thing is the vertebral body, and this is the anterior structure. Okay, and then these are the transverse process. This faint line is the transverse process. So this is after the pedicle, this is the transverse process. So this is a posterior, at least posterior to the vertebral body, and most posteriorly these lamina and spinous process. Okay, lamina spinous process. So you check in this photograph, then this is a vertebral okay, so this is the vertebral body, this is the vertebral body, these are the pedicles, and then behind that is the articular process, and then these are the laminas and spinous processes. So you need to keep an imprint of the vertebral, how the vertebra looks like, that should be imprinted in your head, so that as soon as you see an X-ray, you know that which structure you are seeing. So here also, this is the transverse process, this faint line, transverse process line is a bit faint. Okay, this is the faint line, and this round structure is the pedicle. This round structure is the pedicle. So what is this? I mean, why this is we are seeing as a round structure? Because pedicle cannot be seen in an AP view. You understand that this pedicle cannot be seen in an AP view, because pedicle is ultimately, it is a from body to the transverse process. This is the pedicle. Okay, so this is from lateral side. You can see from anterior side, if you see end on, then only you will see like a round clock like structure. This is like a face of a clock. Okay, so this round structure is, we are seeing the pedicle end on. We cannot see from lateral side only pedicle is seen, and lamina is seen from AP view, and from lateral side this lamina is very narrow part. I mean, we cannot see the lamina. Okay, so you understand these two things. Okay, so this is the spinous process. We understand these are spinous process, they are spinous process, these are the pedicles, and this is transverse process. These are laminas. Here you can see the lamina, this is the lamina, and this is the interlaminar space through which in general anesthetists give a spinal, epidural, whatever. So between the two laminas. Okay, so these are the lamina. So let us go next part. So as I said, first we have seen the AP view. Now we are seeing the lateral view. So in lateral view, what we are seeing, the vertebra, intervertebral, I mean interdiscal space. This is the disc area, which we will not be able to see under X-ray. So intervertebral disc, vertebral body, and these are the pedicles. This is what we were seeing as a rounded face of a clock. I was saying. So this is, we can see from lateral side, but not from AP view. And then lamina. So where is the lamina? So these are the not laminas, these are superior articular process, inferior articular process and superior articular process, which this is inferior articular process, I mean superior articular process, this is inferior articular process. Inferior articular process comes from the upper vertebra, and these are the facet joints, and lamina will be behind that. Okay, so and these are the spine, these are the spines. Okay, so this is the, and this will be the transverse process. It is also cannot be seen, I mean like in this view, you cannot see the transverse process also. So this is the lateral view. So you have to understand by seeing the AP and lateral view which structure we are seeing. We are seeing a two-dimensional structure, but we will see a three-dimensional structure in it while seeing it. Now comes the most important view for most of the 99% of the procedures of pain procedures. Okay, so this is called oblique view. This is we have seen AP, we have seen lateral, and now this is the oblique view. In oblique view, actually what we are seeing this is called a Scotty dog view also. So why it is Scotty dog? We will this is the Scotty dog, Scottish dog, not our Indian dog. So this Scottish dogs, Scotty dog, you have to find Scotty dog like structure here. You have to find, so this is the Scotty dog, a outline of Scotty dog, and you have to find the Scotty dog like structure here. If you can see, that Scotty dog like structure here, so let us see. So this is the eye of the dog. You can see this is like a dog. Okay, so this is the eye of the dog. So eye, which structure makes the eye? This makes the pedicle. As I multiple times I'm telling that this is the pedicle, which is the like a face of a clock. From AP view, this is the eye of the dog in a oblique view. Okay, this is the transverse process. This is the transverse process. So this is the nose of the dog. Transverse process makes the nose of the dog. And then this comes the ear. This ear is formed by the superior articular process of lower vertebra. So superior articular process of this vertebra. So this ear of the dog is formed by superior articular process. Okay, so then neck is that is actually pars interarticular area. So this is the neck, and then foreleg and hind leg. So foreleg is the inferior articular process. Foreleg is the inferior articular process, and hind leg is actually inferior articular process of opposite side. Many things is from those are from opposite side. These structures are actually not needed for us, not that important, because always in this picture we do our procedures in the ipsilateral side, on the same side, not in the opposite side. So the structures of the same side you must remember. Okay, so one is your eye of the dog, which is pedicle, nose of the dog, which is the transverse process, superior articular process is the ear of the dog, front leg is the your inferior articular process, and lamina is the body. Okay, and these things are not that much needed. I mean, like superior articular process of the opposite sides becomes a tail. So that is not needed much. So this is the Scotty dog structure. In oblique view, you must remember this, must find this Scotty dog view. For all the procedures, this will be needed. So here the same thing in the opposite side. Earlier I showed in the right side, now it is in the left side. So same thing, if we have make oblique to the left side, if we want to do a procedure on the left side, we will make the CM to CM oblique at an oblique angle to the same side. I mean, if you want to do a procedure in left side, angulation towards left side, and then left side there will be formed, a Scotty dog will be formed. The same thing, if you want to do a procedure on the right side, you will make the CM oblique to the right side, and another Scotty dog will be formed like earlier, like this. Okay, so ultimately the thing is same. superior articular process, the ear, the eye of the dog, pedicle, nose becomes transverse process, lamina is your body of the dog, leg, inferior articular process, and this area is the pars intraarticularis. Okay, other things are not needed. So, and for remembering, you can say that okay, inferior hind leg is the opposite side inferior, inferior articular process, and opposite the leg is the opposite side superior articular process. Okay. Then comes X-ray abnormalities. So as I told you that I mean this was a classical good X-ray, but whenever a patient comes to you, he will not come with a nice X-ray, or you cannot expect that a normal person will get some injection. They will come, I mean, like very patient will have different X-ray with many diseases. So this type of X-ray is common. So here what we can see the dogs. Okay, so here also one dog is there. This is nose, this is eye, this is ear, and this is the body. Okay, this is the front leg. Okay, but here we can see a small thing, that this neck of the dog, it looks like broken. Okay, other things are there, but neck of the dog, it looks like broken. So same patient, if we see complete laterally, then we will see that there is a listhesis. This is called listhesis, and this is pars intraarticularis fracture. So this is called spondylolysis. This is called spondylolysis, which has given rise to spondylolisthesis. Okay, pars intraarticular fracture is spondylolysis, and spondylolisthesis is this one. You can see slippage of one vertebra over another. So this is less than grade 1, maybe up to 25% is grade 1. So this is a pars intraarticular fracture with this one, your grade 1 enterolisthesis. Then comes this type of picture. This type of picture, what we can see in this picture, we can see very nice laminectomy has been done. In this picture, you can see that laminectomy has been done. This is a post-surgical patient. Here the lamina is there, but here lamina has been cut. Even the spinous process of the L5 is also not seen. So this is a laminectomy. I mean, this is also a laminectomy has been done. So this is common. Okay. This what it is shown. So this is a many findings are there. You can see the vertebral fracture is also there, and then yeah, this is the osteoporotic spine. You can this is the dog. This is a normal dog here. You can see this is a normal dog, but here if you want to find a dog, this is not very common, not very easy, because this is osteoporotic spine, and you cannot see clearly, identify clearly the parts of the dog. But ultimately this eye of the dog, most of the time in a osteoporotic spine also, many times we target this eye of the dog, and that is what is seen. This is also eye of the dog. Rest of the dog you cannot see, but this is the eye of the dog. Okay, so this is one thing. Then kyphoscoliosis, this is too much of scoliosis is there. So this thing you can see, these are abnormality of the spine. And then other things, like say these are the spina bifida, which is a spina bifida. So these are congenital anomalies, and nothing that patient got any trauma or surgery and developed this, nothing like that. This is for patient is born with this. So this we can see. And then this is a Bartolotti syndrome. We can see this transverse process has become so big that it is forming a pseudojoint over the sacral ala. So this is a Bartolotti syndrome. What is the importance? The importance is we can put an injection here, but if we want to put an injection here, there is space is very less. Okay. Then come, this is the very long spine. Okay, very long spine. You can see that how many, if this is the last rib and this is T12, then 1 2 3 4 5, then where from this vertebra has come? So this vertebra is lumbarization of sacrum. Lumbarization of sacrum is possible. So there is 6 lumbar vertebra. I mean, one S1 that it has become like lumbar. and say this one is your this is the last vertebra and this one is T12. So this vertebra is there, T12 is there. So 1 2 3 4, where is the fifth vertebra? So this is the sacralization of L5. So both is possible. And if say patient is telling that patient I mean like patient is having L5 radiculopathy, then where you will inject, because L5 is sacralized, L5 is with the sacrum. So you have to think that where the root is coming out, through which the root is coming out. Then come this type of bamboo spine, and then these are hallmarks of inflammatory uh, inflammatory spondyloarthropathy. So these are the okay, ankylosing spondylitis. You will get this type of spine, and this is the osteophytes. These are the osteophytes. So always see an X-ray and try to find out that what is osteophyte and what is syndesmophyte. These two things are different, because only giving injection is not our aim. We need to know that what is underlying diagnosis, why patient has developed. So this gives you a diagnosis of degenerative condition, right side, this one osteophyte, and this gives you a diagnosis of inflammatory condition, inflammatory spondyloarthropathy. So and then this type of spine also you will get, where so much of pedicular screw fixation has been done. What is the importance? You will be having a trouble to put your needle in the right place in these type of cases. So that is also common. And then as I told you that most of the injections are done in this view, oblique view. First, we start in the oblique view, though there are other two steps that will be shown by Dr. Devjyoti, but ultimately, before putting the needle, patient will be we will get this view, oblique view, which is called a Scotty dog view also. Why? And then most of the injections which injection I'm talking about, that I'm telling, that if want to go to you want to target facet joint, say, so this is the facet joint, you can go intraarticular to give intraarticular facet joint injection, or you can target a medial branch block to denervate the facet joint. So this will be the medial branch area where you can give injection. So this eye of the Scotty dog is the target point for medial branch, eye of the target, Scotty dog. And then you can see the intraarticular position also. If you want to enter in the disc, so you can enter in the disc through here. Okay. And then if you want to do a transforaminal epidural, as we know, epidural space is we are anesthetists are more accustomed to do an epidural through interlaminar space, like here this is the space, either you go midline or you go paramedian, but it is the interlaminar space. But in pain practice, in pain, physicians will go epidural, he will approach here just below the pedicle, just below the pedicle, to one pedicle to another pedicle. This area is a foramen. Okay, this area is foramen. So you can see, so this area is a foramen, and you can see that above the foramen also is a pedicle, below the foramen is also is a pedicle. So this is the foramen. Okay. So while seeing the thing, seeing the picture, I mean, you have to understand that between two pedicles there is foramen. If you and if you say there is a this is the picture, and from posterior side you are going, so you have to understand the depth also. First, from posterior side you will enter in the pedicle, and if you go forward, so either you get vertebra or you get disc. Okay. So if you are here, you will get into disc. If you are here, you will hit the vertebra. Okay. Then comes some theoretical part of uh, transforaminal epidural part. So as I told you, that when you are seeing the epi view of the vertebra, then you need to understand that through which area this we can see the bones but not the soft tissue structure. So you have to imagine that where the nerves through which area the nerves are going. So this area, a nerve is going like this, from the upper this part, from this part to down like this. Okay. So here also you can see from upper pedicle, this is the expected root of the nerve. Okay, so you can see if I have drawn here. So here is one pedicle, yes, pedicle, eye of the dog, and here is another eye of the dog. So between these two eyes, there is the intervertebral space, intervertebral foramen, through which we can go to the epidural space, and nerve will be passing like this. Nerve will be passing like this. Okay, you can see from here, nerve will be passing like this. Nerve will be passing like this. Okay, it will come from here and it will go anteriorly. Three. Okay, it will go anteriorly like this. Okay, like this. Okay, so this is what I have shown here. Okay, so this is the nerve root. And now another important theoretical thing, of course, but this is very important, that if nerve goes like this, it forms one triangle above the nerve and one triangle below the nerve. So these two nerves have two names. This below the nerve triangle is Kembin's triangle, and this above the nerve triangle is safe triangle. Okay, just a minute. Okay, so these two triangles are very important. This is called safe triangle. This is called Kembin triangle. Through Kembin's triangle, nowadays we inject, we put our nerve injection, put our spinal needle to enter in the epidural space. And earlier it was used, the safe triangle was in much use, because it was thought that space in the safe triangle you are safe. You are safe means what? Means that if you inject here, you are not going to inject drug in any vessel, you are not going to puncture any vessel. But later it was found that no, more vessels are there, and it is considered as now unsafe triangle, not the safe triangle. But anyway, the name still remains safe triangle here and Kembin's triangle here, but Kembin's triangle approach is more commonly done. So here you can see that if just under the pedicle you put your needle here, you are in the safe triangle. And if you put your needle here, this is the Kembin's triangle approach, and nerve will be going through like this. Okay, here in AP view, oblique view also, you may think that nerve is going just laterally, but it is not that going last laterally, it is going laterally and anteriorly. Okay, so but it will go between these two. Here we will put, this is the oblique view, we are putting a needle here. We are when after putting the needle here, when we check in AP view, our needle looks like this. It will be just under the pedicle. Okay, so same thing in this view, I mean, like your oblique view, Scotty dog view, we are putting just below the pedicle. So this is a safe triangle approach. And then in laterally, so this will look like, this needle position will look like this. And in AP view position will look like this. And in lateral view, we can see the needle tip has come in the foraminal level in the upper part. Okay, and the second one is in the Kembin's triangle approach. So here also, this is in the oblique view, this is in the AP view, and this is in the lateral view. In here and here, what is the difference? The difference up in upper one is, it is just below the pedicle in the upper part of the whole foramen, and it is in the lower part of the foramen. Means nerve is going below it, and here nerve is going above the needle. Okay. So ultimately, when for any injection, before you give drug, you have to give contrast. Otherwise, you don't know where the you do not want that your drug goes inside the vessel. Neither it will work, or it will cause complications only. So you will put contrast. So after this is a after putting the needle, after putting the contrast should go in the epidural space. So it is just going inside the epidural space. So this is a nice contrast distribution, and this is in the anterior epidural space. The contrast is going up like this. So here also another contrast distribution. You can see nice contrast distribution, nice contrast distribution. And okay. So this is a actually while giving contrast, we have to always be vigilant that if a small portion of the contrast also going in the vessel or not. So here it is a small portion of contrast is going in the vessel, which is very faint to see. But if we do an DSA, then we will be able to see that some portion is going in the intravascular region, intravascular injection. So we should be always very much vigilant that nothing should go intravascularly, and this type of contrast distribution is expected. Okay. So so this is also the same thing. These are also contrast spread. These are contrast. These are again. So this is a contrast spread through S1 foramen, and this what I am saying is an intravascular contrast spread. So this is a DSA picture, but in X-ray also this type of picture you will see. So this is the what is the how you will understand that this is an intravascular injection, because within seconds the contrast will vanish. After giving the injection contrast, you when you give the exposure of X-ray, immediately you see this type of picture, and this is you can understand that these margins are so smooth that it is a vessel only. And again after 5 seconds, if you inject, you will see these things are vanished. That means intravascularly contrast has gone. There is another intravascular picture. So and this type of picture is not, this is not going in the intravascular, but this is also not very expected distribution, because a lot of contrast is coming outside this side. It should go up, it should go up, and it should not come outside. So this is also not expected. Okay. So this was the transforaminal injection and few lines about the facet injections. So okay. Facet joint, as I told, the facet joint is like this. Yeah, from here. So okay, so this is a facet joint. So this is the superior articular process of the lower vertebra. This is the inferior articular process of the upper vertebra. So if I want to inject inside the facet joint, this is all right. This space is very much thin, but we can denervate the facet joint also. We can just cut the nerve supply of the facet joint so that it doesn't pain, because evidence level of this denervation of median branches has the more evidence. It gives better result than intra-articular injection. Nowadays we go to only denervation process procedures. So here there will be one median branch, and here there will be one median branch. Each facet joint is supplied by two median branches, and two median branches will be will be available on the respective vertebras, this superior articular process and transverse process junction. Okay, or eye, over the eye of the dog, if this facet joint, we will inject here and here for two nerves for each joint. If this facet joint is involved, then we will inject here and here. Okay, and this is the facet joint. You can see this is the soft tissue structure. If we could see the soft tissue structure, then we would have seen the one facet joint, median branch here and one median branch here. These two median branches supply the facet joint in between. And as a theoretical knowledge, if it is L4, it is L5, then we will, for L4-5 facet joint, we will inject over the L4 over this eye of the Scotty dog of L4 and eye of the Scotty dog of L5. And these median branches are not L4-5, they are L3 and L4. Over the L4, median branch is L3, and over the L5, median branch is L4. Okay, one branch above. I will send the study material, there you read. Okay, so ultimately, if we inject here local anesthetic, if we inject here, that is sufficient, that will spread over the area and block the median branches. Okay, so these are the median branches, and our target is eye of the dog. So for blocking the median branches, even in the median branches injection, we have found that intravascular injection can happen. Okay, so this is the AP in the oblique view, and in AP view it looks like this. So this is the same thing, intravascular injection. This is the lateral view. This is another type of needle positioning when we go for radio frequency of median branches. Then lateral pictures gives this picture, and AP view is this picture, like this. Okay. And intra-articular facet joint, if we give intra-articular injection, very rarely we get this type of nice picture. I mean, the whole joint is this inside the joint. You can put the needle, and this is the picture, very nice picture, which is showing you the whole joint actually. The contrast if you give inside the joint. But as I said, this is this is every time you will not get, because joint can be torn, there may not be adequate space, but you can feel that whether you are inside the joint or not. Okay. So okay, Dr. Devjyoti will now show everything over the mannequin. Yeah, yeah.
Actually, one question was there. Is before formalization and normalization.
Okay, okay, okay. Please explain S1 transforaminal block. S1 in okay module that, yeah, we'll see in another. Will defer the needle entrance if I will do median branch block or RF. Yes, that Dr. Devjyoti will show you that it is not the same. When you do block and when you do RF, the needle positioning is different. Okay, and sacralization and lumbarization. Repeat the slide. It is nothing big, no. I mean, that is very common thing. Yeah. So yes, this one. I'm sharing or not? Devjyoti?
No, you are not sharing.
Oh, I'm not sharing. No? Okay, okay. Share screen. Share screen. Okay, share. Okay, so this is you can see, no, if the last vertebra is from T12 most of the time. So I mean 1, 2, 3, 4, 5, and this is S1 vertebra. So after the sacrum S1 vertebra, there is usually you cannot see a disc space or this I mean intervertebral interlaminar space or something. So
The slide before this slide.
before the slide.
Yes. Probably, please open your microphone, switch on your microphone, and see what you want to know about the Bartholdi syndrome.
Yes, boss. I think
Yeah,
he
ask
wants
me,
to about. He wants to know
Hello?
about that only. Yes,
Yes,
boss.
Am I audible?
the name of syndrome. Can you repeat this part again?
Oh, this part. Just
About this syndrome, you have mentioned the space
oh,
is
okay, okay,
closed.
okay. This space is, oh, okay, okay. This one you were saying about. So this is Bartholdi syndrome. This is called Bartholdi syndrome when the transverse process, which is this small, no, this is the normal transverse process. This is the normal transverse process. This is the normal transverse process. But whereas in these vertebra, this transverse process has become so big that this is forming a pseudo joint. This is not a right joint, but this is forming a pseudo joint over this sacral ala, and then what I mean, what is the implication for us? For us, this foramen, this area, it is so big area. Okay, if you want to put your needle under the pedicle, here you can put here, and here also if you want to put a needle, at least space is there. But here, where is the space? This space is so small. If you do oblique, then space will be totally obliterated. And in the APVU, if you will put a needle, this will never go under that foramen. Okay, for going medially, you have to put your injection more laterally. From lateral side, if you enter, then only you will go medially. Okay, and so here from laterally you can go because there is a space, but here there is no space. That is the importance. And sometimes this pseudo joint also causes pain. So that is also. possible. Then you have to think that if this type of patient comes, then you have to think that what in other way you have to do the procedure. No, you want to say someone having L5 radiculopathy and this having the same joint, and you know that L5 root is coming through this, then you cannot go here. No, then you have to go through S1 foramen, and give drug, so the drug moves in the epidural space and bathe the L5 radical. So that will be a different approach. Okay, then we go to the practical part now. How to decide the level of, yeah, WT, you start.
Okay. Is switch on from switch off from there. Both speaker and microphone. Hello. Am I audible?
Yes, boss.
Okay.
Oh my God, so much of echoing is there, I think.
And now it is stopped because we are in the same room. That's why some amount of echo was there. But now we have stopped one this
Okay.
laptop. So
No
then
worries,
we
no
are.
worries.
So here today, what I'll be describing is these two procedures, what is discussed. So before doing the real procedure, just a few things I need to state about the radiation safety, because this is important. Whenever we are using this machine, that is the fluoroscope, we have to be careful. So how to be safe? Just 2-3 few points that we should remember always. Number one of the most important thing is the distance. So if we are distant from this machine, so this is the emitter. So this lower portion below the table actually emits, okay, the portion below the table that emits the extra radiations, and this is the receiver. This is the image intensifier. So it receives the X-rays, and that is transmitted to the, converted to the electrical signal and transmitted to our monitor. That's why we can see the images. Here, few important tips that if you want to zoom anything in the body, what you need to do, you have to reduce the distance from the emitter to the patient. So this is the mannequin, and we can consider it as the patient. So we need to close it, because it is like a bulb is there and we are putting our hand. So if the hand is closer to the source, the shadow will be bigger. In the same way, if we want to see or zoom our image in the CR, we need to close this distance. Okay, but this trick increases radiation. So we should try to keep it less zoomed, and always try to use minimum exposure as possible. So minimum shots, not use of continuous shots, using a large room so that we can maintain a larger distance from the C-arm. These are very important, but not all. It is by itself a chapter, and always use this material. They are attenuating materials made up of either lead, bismuth, or this type of materials that can attenuate these X-rays. So that are few basic tips that we should maintain. Now, few basic movements. Okay, so let me share you the other camera. Okay, now can you see the image from two cameras? Just do one thing, make it a single speaker view. There will be, if you full screen, there will be 4 options. In the first one, that is the hide the thumbnail video. The second option you choose and make it slightly larger so that you can see the C-arm from 2 different views. Okay, and you can move one picture, one camera picture, that is the speaker's view, anywhere you want in the screen, and you can reduce or increase the size. The other camera is fixed, that is with the shared content. So we have put the C-arm in such a way that you can see the views from two different angles and they are mutually at 90-degree angles. Okay, so you need to know the basic movements. So this image intensifier, when it is moved towards the cranial side, okay, move it towards the cranial side. Don't take any shot, just move it towards the cranial side. Can you see? This portion is the head of the patient or the head of the mannequin. So what is the name of this tilt? As the image intensifier is moving towards the head end. So this is known as the cranial tilt. So often we will be referring this term that now we are tilting the C-arm cranially. You should understand we have moved the C-arm in this way. Next is the opposite. Okay. Do tilt towards the opposite side. So this movement, can you see? No one is responding. Is the speaker working?
Yes,
Yes,
Bob,
sir.
I can hear you.
Okay. Just anyone, just give answers because otherwise it is very difficult to understand. Okay, what's going on there. So this movement is known, this is very basic. This movement is known as the caudal tilt. So we can move the C-arm in cranial tilt and caudal tilt from AP view. Make it perfectly AP once again, AP. Now this is in perfect AP position, but he is moving. Now we can move it to the other direction as well. Okay. So what direction we can move? We can move it towards the oblique. Okay. We can move either left oblique. So see this movement. We'll be able to see this movement with the other camera. So this is the left for the patient. It is the right oblique. Okay. Now, if we move towards the opposite side, it will be the left oblique. And we can see completely rotating it towards the lateral side. Then it will be a lateral view. So we'll be referring these terms left oblique, right oblique. And if we are doing any procedure is in one side or any, this is lateral. Okay. So next move again to the AP. Now this oblique we will be saying sometimes ipsilateral oblique and contralateral oblique. So what is ipsilateral oblique? Suppose the pathology is in left side of the patient. So this side is the left side of the patient. So if the pathology is this side and we are making oblique to this side, okay, make oblique to pathology is in this side. Okay, see the front camera and we are tilting the C-arm towards the same side. So you will be calling it ipsilateral oblique. Now, if the pathology or our procedure site is this side, that is the left side of the mannequin, and we are tilting to the opposite side. So it will be called a contralateral oblique view. Okay. Certain procedures like facet, they are usually done in the ipsilateral oblique view. Whereas certain procedures like sacroiliac joint intervention, like cervical epidural confirmation, they are done in contralateral oblique view. So this thing's clear. Few initial words of the radiation safety. One of the most important thing is using less number of shots, using less KV, maintaining distance, using large loom, using attenuating material. So these are important for the radiation safety. And these views I have shown you the cranial tilt, caudal tilt, ipsilateral oblique, contralateral oblique, and the lateral AP. Okay. So I think if this is clear, most of you might know this, but anyway, for those who are new to it, so I'm just describing this part. Now we are going for the lumbosacral procedures. So what we'll be doing? We'll be putting it towards the exactly AP view. Okay. Now we are putting the C-arm in the AP view and we are taking a shot. So what we will be able to see?
Yes.
Now see the screen. So here first, in any procedure, we need to do two things. One is level determination. That means at which level we want to do the procedure. Is it L4? Is it L5? Depending on that, first we need to choose where we have to do the procedure. Okay, doing a procedure in wrong area, ultimately you won't be getting the result. So there is no point doing such intervention. So to mark the level, you have two ways. Number one, what you can do, you can count from below upwards. So this is the S1. Next, this is the L5. This is L4, L3. Now, there are conditions like lumbarization and sacralization that can actually change these positions. Suppose S1 is lumbarized. That means this vertebra has moved to upper part and it is looking like L5 vertebra. How to understand that? For that, you need to move up. And what you need to do? You have to come to the T12. Move up. We are not changing anything in the AP view. We are actually moving up. Again, slightly more up. So here, where we are getting the last strip, this is D12. Next, L1, L2, L3. Now, if I draw in the skin, it is not possible. If we move it towards the lower side, it will be vanished. So what we can use? We can use a pointer. Give me one pointer. Pointer. Where is the pointer? Oh, here. Okay. So for those things, we will be using a pointer. So you can use anything like a forceps, okay, or a needle or any radiopaque object to mark the area. So I want to mark the L3. So take a shot. Take a shot first. Okay. So can you see the needle tip? Sorry, not the needle tip, but our instrument tip. The artery forceps what I have kept, the tip is at the level of the L3. Now we can move down to check. Move down. Further down. So as I have checked, this is L3, L4, L5, or move further down. So what happened? Okay, this L2, L3 has moved because now the screen drawings cannot be the same. So this was the L3, L4, L5. Okay, so this becomes S1. So the patient is not having any lumbarization or sacralization. So this is the first thing you need to know. So now I have perfectly determined the L3 and L4. Okay, my tip is at the L3 and the lower vertebral body is at L4. Now, if we want to do a facet joint block, the first step of doing it is the marking the site, number one, level. Number two, what is important is we need to know the side, left side or right side. So what we can do, again, in the same way, I am putting another marker. So it is like an arrow. It is like an arrow. I am putting this marker to the left side of the patient. And then I am taking, okay, so my left side of the screen is matching with the left side of the patient. So now we know the side, now we know the site. Okay, we know the level and we know the side. So next, suppose I am suspected, I am first starting with the facet. So if I have suspected my right-sided L5S1 facet is painful. So we need to go for an intra-articular diagnostic block. So what we need to do? for the intra-articular diagnostic block, we need to first step squaring of vertebra. We need to rotate our C-arm in such a way that this oval shaped lower border becomes one line. Okay, so for that we need to take help of the cranial and caudal tilt. Okay, so here as we need to do slightly, first we are doing a little caudal tilt. Take the caudal tilt, caudal. Check in the other camera the C-arm movement. Okay, slightly more caudal tilt. Let's see, we do not know. Usually in the lower portion, cranial tilt is required. In the upper portion, see. Here, when we have done the caudal tilt, see, the oval shape is increased. So this is not the right direction. We need to move towards the opposite direction. Okay. So we are making it slightly cranial. Check. See, now the lower border is becoming a line. Okay, not perfect line yet. Arektu comma beshi hoye geche. So let us remove this as well. Arekta check karo. So it is not perfect. Arektu matho dike tilt karo. Okay, tilt towards the cranial tilt. Okay, now it is almost looking, they are almost looking like a line. Okay, this is one line, this is another line. So now we can say this vertebra is squared. Sometimes it may not be possible to square both the plates in the same view, but in this view, it is squared now. So now we need to, I have told the patient is having right-sided facet pain. So we are moving it towards the right lateral. Now, how much lateral? It is said that this facet joint, okay, it will move. This is the facet joint. The distance from this vertebral end and this vertebral end should be almost equal. So here it is not equal. So we need to tilt it further oblique. Oblique, correct. All right. So now it is almost equidistant, okay, from here and here. Okay, this is done slightly more. Now we are able to see this Scotty dog. A Scotty dog is described right now by Chinmayda very clearly. Okay, so this is the Scotty dog. Now for the facet joint block, we need to go to this area. So this is the ear of the Scotty dog, and the ear and front limb of the upper Scotty dog, they forms the facet joint. So once we have located our site, then we're trying to make the facet joint open. All right, now we can see a open facet joint. Okay, so this is the one line, this is the other line. So these are the facet joint opening. So once we got the opening of the facet joint, next we need to again put a marker. So we are putting a marker. Check. And we will be marking the joint line. So marker we need to move up. Check. And it should show you the entry point. So we are getting the entry point. Next, to enter the joint, what we need to do? We need to take a needle, and the needle tip should be slightly bent we are taking this needle. So this camera is a better camera. So can you see this needle tip? Visible? Huh? Not visible. Not possible. So here, let's try in this. Can you see the needle tip? Visible? Not. Now I think it is comparatively more visible. So we are bending the needle tip towards the notch or opposite to the notch, and we should know where we have bent. So here we have bent it towards the notch. Okay, here is the notch in the needle. So now the advantage of bending the needle is here the needle is slightly bent, that we can rotate it inside the patient. So now at the needle entry point, let's move this camera forward so that you are able to see the needle entry.
Can I just ask a quick question, please?
Okay, can you see it? We have our pointer.
Yes, sir.
So our tip is located, it is showing our entry point. So at the tip, first I will give local anesthetic. Here it is mannequin, so local anesthetic not required. I am just putting the needle in the direction of the C-arm. Okay, so beam is like this, and our needle I have put is like this, exactly in the same direction. And next we will be checking the C-arm view. So now see the tip, and here you can see the tip. Here we can see the hub. So it is not exactly under tunnel vision. So what we need to do? We need to place it in such a way that it goes into the tunnel vision. Okay, next view. Sorry. Check. Now the tip has gone slightly more medial. So this is the adjustment, and here we need to adjust it in such a way that gradually the tip comes towards the joint. Check. Now our needle is becoming more of a dot rather than a line. Chalo, check. So here our needle length further reduced. So we are trying to make it more tunneled, and we'll be now entering, because this is now almost at the tunnel vision. So can you see the needle now? It has become a small dot. Like here, okay? It is a small dot here. We are no longer able to see the whole length of the needle. Now we need to put the needle down so that it reaches and touches the bone. So we can see the needle tip here, almost at the center of the facet joint. This is the needle tip. Now we have touched the bone as well. We need to enter the facet joint for the intra-articular block. So now we are entering the joint. Now I have entered. I am getting the feeling I am going in between two bones. Okay, check once again more. Okay, now we need to confirm. Okay. So how will we confirming? We can confirm in two ways. One is the continuous view. So in the continuous view, we can check, or in the lateral view we can check. So continuous view actually causes more radiation. So we are going for the lateral view. Go to the lateral view. Check. So it is at the facet joint. Okay. So we cannot see in the needle tip because it is inside the joint, but it has not gone anteriorly, neither it is posterior. Okay. It is exactly at the joint level. Acha. Ek to continuous dekhiye na. So continuous is not recommended because of more radiation, but in the continuous view, we can check that our needle tip is inside the joint. Okay. Alpo check. चलो अल्प पकड़ देखिए वीडियो था ओके okay, so we can see the needle tip here. Chalo. We can go like this also. Okay, so that is the intra-articular facet. Take another AP view. Okay, now we are going for the median branch. Okay, medial branch. So where is the medial branch? It lies at the junction of the superior articular facet and the transverse process. Okay, so this is our target here. Okay, and for the medial branch, we can go either for the diagnostic block or for the radiofrequency ablation. The difference in between these two procedures are very simple. For the diagnostic blocks, we can go with our normal spinal needle, and here we can go under tunnel vision. In radiofrequency ablation, we can go under tunnel vision, but here the preferred view is not the tunnel vision. Here we want to try to keep this radiofrequency needle in parallel with the nerve, because our radiofrequency lesioning is not at the tip. Rather, this is the radiofrequency needle. Okay, let me show you the radiofrequency needle. This is the radiofrequency needle. Our radiofrequency needle, just check. Okay, visible. So it has an active tip. So we can see the active tip and a insulated portion. Now, around the active tip, this steel portion, okay, this bright portion, the lesion occurs. So while doing the lesion, we should be careful that this active tip remains parallel with the nerve. So for that, what we need to do? Again, we need to follow the initial steps to get a Scotty dog. So rotate it so to get a Scotty dog view. We are doing the procedure at the same level, but rotate, but do this time on the other side. Okay, this side. So because that side the camera is, so it will be easier for you to see. All right. So here, if we want to do, this is the superior articular facet, and this is the transverse process. So the junction is our target, and here we'll prefer to enter from slightly below. Chalo, sorry. Let's check. Okay, so we are taking the entry point slightly below the maybe a level or half level below. the desired target. Now, from this target, we are entering, and here our first target is the pedicle. So, with the needle tip, we'll try to reach the pedicle first. Chalo, देखो. So, we are moving towards the pedicle. Chalo. Here, I have to be careful not to cross, rather we will change the direction. Chalo. Okay. So, my target is to touch the bone, not to go further at this point. So, here I got the sensation in my hand that I have touched the bone. Now, the thing is very easy because we know the depth, and now we are moving slightly, walking over the vertebra. So, here with the needle, I just walked over the pedicle to the junction of the transverse process and the superior articular facet. So that was my target. And now we need to check in the lateral view as well. So check the lateral view. Okay, so we are exactly at the target. Our needle tip is here. It has not gone anteriorly towards the foramen. And remember, from the tip, we are not doing the lesioning. That is the advantage because our this active tip portion is over the junction of the pedicle and superior articular facet. This portion is the active tip portion of the needle. So that is how we need to place, and at this point we need to first go for the sensory stimulation, and we need to check the radiofrequency machine. We will be describing in another class as well how to use the radiofrequency machine and the details. So here we need to first go for the sensory stimulation like a nerve stimulation, that where the pain is, whether it is matching or not. Next, we need to go for the motor stimulation, and we all know this medial branch of dorsal rami of the spinal nerves supplies the multifidus muscle. So we'll be able to see the multifidus contraction. So once these two things are fulfilled, and also remember the stimulation should not go to the legs, because if we are closer to this is the foramen. Okay, if we are closer to these foramens and this nerve comes like this, so if we go much inside, we might touch the nerves. So in that case, we will be getting the stimulation of the leg muscles, and that is not desired, and we will not be wanting that to happen. So once we are confirmed that our contraction is only multifidus, it is not contracting the leg muscles, and the pain produced is matching with the paresthesia. So we are sure we are at the perfect location to doing a radiofrequency thermocoagulation of the medial nerve at that point. So medial branch, we can block there with the radiofrequency and the patient will be pain-free. So that's all about the medial branch. And last part is the transforaminal for today. So here, for the radicular pain, we need to come to these areas. These are the nerve roots. So these are the foramens. So we need to come towards the foramens. Okay, let's see. Again, we need to start from the same position. AP, first AP. Next, time oblique. So again towards my side. So first I am doing a, oh no, you have to change the correlated cranial tilt. The squaring is not done. Okay, let's say we are doing at the L3, L4 level or L4, 5 level. So which level? Square tilt account. Chalo, okay. Okay, now if we are doing at this level, okay, so we need to make it slightly more oblique, slightly more oblique towards that side. Now imagine the nerve here. So I'm drawing in green the nerve. So if the nerve is like this, so if we go through this red triangle and this yellow triangle, this yellow triangle is known as Cambind's triangle, and this red triangle is known as the safe triangle. So which one is the preferred? Safe triangle or Cambind's triangle?
Cambind's triangle.
Cambind's triangle.
We will try to go through the Cambind's triangle, and I will show you the safe triangle method as well. So first we need to put the marker at the level of the Cambind's triangle. So we are putting the marker slightly lateral and below. So here we are going almost at the facet level, but here we have to go towards the superior articular facet. Okay, so that is the area, because if here is our nerve, we have to be closer to the superior articular facet. So we have taken the, here we will be taking a normal needle, that is the, and we are taking the surface point and we are entering here. Check. So can you see the needle tip? It is almost by the side, slightly by the at the side of the superior articular facet. So now we need to enter at this level. Chalo. So our needle is moving towards the Cambind's triangle. Here we need slight manipulation towards the lateral side as the needle tip is going further medial. Now we are tunneled. And can you see one dot here? Our needle tip is now no longer a needle, it is now a dot. This is now a dot. So now here remember, we should not go further in because this is no hard target. Previously, we are going towards the pedicle, so that was a hard target. We are going towards the facet joint, that was also a hard target, that means bony target. But here our target is soft, because if we go further in, it might go inside the disc, it might go inside the nerve. So here, once it is perfectly tunneled at the superficial level, we'll make the C-arm lateral. So let's move towards the lateral side. Down. See, our needle is tunneled, but your direction is right. So we need to just with the we need to just put the finger, okay, like this. So just we are not changing direction, just pressing it inside so that it will go in the tunnel view. So now we are at the posterior inferior part of the foramen. Can you see that? This is our needle tip. This is our needle tip. Needle tip. So this is our final needle position. Here we will put the dye and we'll see the dye distribution that already Dr. Chinmara has shown. And after checking an epidural distribution, we have to go for the transforaminal steroid injection. Last thing is left is the safe triangle method. Again, come back to the previous level. It is the same. Here the needle will move above the needle, above the nerve. Chalo. Okay, fine. So in this method, the entry point will be slightly up. Check out. So that is the subpedicular, just below the above pedicle. And here we are taking another entry. Like height बढ़ावे. ठीक है. देखो. So, can you see the needle just below the pedicle? It is moving slightly up. So, we need to change the tip of the needle towards the slightly down and slightly towards the medial side. Chalo, now it is becoming tunnel again. So it is going at the subpedicular space. Check. Now it is tunneled, so we are making lateral. So in this view, we need to enter the needle slightly. Chalo dekho. It's going in. Chalo. So now it has reached the epidural space here at the foraminal level. So this is the safe triangle approach. But as you know, the vessels like artery of Adam quiz, they enters at this place. So we should not be doing anymore this method. Okay. So the preferred method now is the Campbell's triangle approach. Now coming to the questions, how to decide the level of the transforaminal epidural injection in different type of disc prolapse. In fact, you have already answered this question. You have answered or not?
I've written in chat.
Okay, then it is fine. Already answered, but the simple answer is here. If previous views was that at which level the radiculopathy is, but now the views are it should be at the shoulder. That means if there is the L4-5 prolapse, then we will be giving the at the L4 root. That means yes, L4 root, but with above level, but previously it was the below level. So that's all about it. This lambdization, we can check on pre-procedure or extra reduce the exposure. Yes, that can be done. It can be checked in the pre-procedure to extend the reduce the exposure, and in the pre-procedure MRI as well. I think the front camera is showing the mirror image. Okay, I have just noticed it can be changed easily. Okay. Is not what showed now, the right side. Yes, previously the first procedure I have shown in the right side. Next, all we have done in the left side. How to decide the level of, definitely it is a combined decision, not only on the MRI, not only on the clinical. Okay, nowadays it is depend on MRI and clinical both. So that was all about the questions. So if you have any questions, you can ask me. Just unmute and ask.
Sir, how to perform S1 transformer?
S1 is in the module 4. We will be
Okay.
showing that also.
Okay.
Any other questions?
Yes, you said we will be bending the needle. Can I ask
Yes.
which direction we will be bending? Is it towards the bevel or is it against the bevel?
See, it depends on you, that you have to remember you have directed needle towards the notch or opposite to the notch. If you bend it towards the notch, it will be towards the bevel. And if we make it to the opposite, it will be opposite to that bevel. But most important is you should remember where you have bent. Better is opposite to the bevel or opposite to the notch, because in that case it is easier to take the stillet out, but it is a very minor level of change. So you can, I initially practiced with the towards the notch and towards the bevel, so I still follow that. But if you practice from the beginning, there is a slight advantage on that. Okay, doing the opposite, but not a major advantage. Only the thing is, it is comparatively easier to take the stillet out.
Thank you.
When we are performing medial branch radio frequency, final target is junction between transverse process and superior articular process. But we are approaching the pedicle in the first and trying to make our needle tip parallel to the nerve.
I could not understand the question again. Can you repeat it, please?
When we are performing medial branch radio frequency,
Yes.
the final target to put our needle parallel to the nerve at the junction between transverse process and superior articular process.
Yes.
The first target to hit is the pedicle. Is any specific site or clock at the pedicle?
No specific site at the pedicle, but you try to hit the middle of the pedicle. Okay, because then it is easier.
Again, please.
Actually, the thing is, if you are a beginner, you can do it in the tunnel view as well. But the only problem is that with the tunnel view, the methods are not as good at the parallel movement. Okay, it is like this. So I am showing it in a model. So this is the radio frequency needle, and this is our vertebra. So here, see, when we are coming, I'm showing it towards you, okay, and I'm putting it exactly how it is put in the Scotty dog view, okay. So here when we are moving, if we go like this, if we are touching the junction like this, the problem is the lesion is not occurring at the tip, it is occurring at the side. So if we go like this, first hitting the pedicle, then moving up like this. So what happens here, more portion of the active tip touches the nerve. So
Yes,
that is why we came from below and we put the like this.
Okay, I got it. Thank you.
Because lesions are not at the tip, lesions are at the side.
Circumferential, below the tip.
Yes, it is below the tip. So we want to keep the below the tip portion close to the nerve.
Thank you, doctor.
That is why we do not do the tunnel vision.
We will be discussing more detail when we'll be talking about the radio frequency. Then you'll be understanding that the conventional radio frequency, you need to put the needle parallel to the nerve. Okay, somebody actually requested at the beginning that the recording should be available more than 1 week period, but that is not possible. When you'll be recording this one, the earlier recording will be automatically deleted and not in the crowd, because we are taking almost 3 hours class, so it is a very heavy file, and this much of file we don't have that much of storage, so that the other things. So it is not possible. So in 1 week time, it is your responsibility to read it again and again and again, go through as many time as you wish. And please make the things stored in your brain. So that should be done. And another thing which is I am not feeling happy, because many people are leaving the meeting. So what I'll be telling you, please, even if the meeting recordings are there, even then you can clear your doubts when you are having the live classes. Otherwise, there are lots of lectures also available in the YouTube. So live interaction is more important. So please try to, at least for these 3 hours, try to be there with us and ask your questions, clarify your doubts. And another important, as I told at the beginning, that please subscribe to our channel. It is free, the Rodya Pain Clinic YouTube channel, and you'll be getting lots and lots of clinical method lectures. All the clinical method lectures are available: shoulder, back, the knee, everything. And apart from that, there are a lot of other lectures. So please go through those lectures. And if you're having questions, you can ask me all the time. At the beginning, at the end, we are always giving you the ample of time to clarify your doubts. So it is almost 9. So long, exhaustive session. Should be again requesting you, please keep at least 3 hour time. Sometimes we are competing by 2.5 hours. Sometimes it is stretched up to 3 hours. So please be patient to listen all those things and participates in the live interactions.
Thank you, sir.
Debjyoti and Chinmay, both of you have
nothing much, just a request to link your account. Invitation I have sent more than 10 times, except one who is having this licensed account. Apart from those, please link. Otherwise, it is very difficult. Again and again, you are coming and in the waiting room, and we have to accept you. So
if you are registered, there is no waiting room. You can directly join. So please register. Registering will be making you direct entry. Otherwise, you have to wait in the waiting room, and our people will be matching your name. So it will be a long, hassled procedure, lot of hassles. So if you are registered directly, you can go enter into the meeting.
Sir, can I ask one question, sir?
Yes.
Sir, I will like to ask you about the dye spread, sir. The mixture of the ratio, how we mix the dye. Actually, what, sir, I have tried many times and I'm not getting the actual dye spread. So what is the ratio of mixing the dye with the distilled water? Or
the thing is, if you use the concentrated dye, there are two problems. Number one, that putting the dye is thick, so injecting it through the needle is difficult. And number one, if you do any mistake, your needle is not placed perfectly at the first time, then what happens that you cannot try for the second time. So what we usually do, we usually use a 50% dilution with the normal saline or distilled water, whatever you have in your OT, just mix it and make it 50% diluted. Then inject and check. The advantage is that this is easy to inject, and number two, if you have a next chance, if your needle is not placed properly, you can replace it and use the concentrated time on the second time. So that is the advantage. So initially it is 50%, that is the best.
okay, sir. Thank you, sir. Thank you.
Okay.
Yes, sir.
So there is no hard and fast rule. At the end, there is no hard and fast rule. It is always easy. What Debjyoti told, try to do a 50% dilution, half of your dye and half of your normal saline or distilled water. And if you need later on, you can make it more concentrated. That means 3 part dye, 1 part water. Initially 2 part dye, 2 part water. Water means normal saline, or sometimes water for injection.
Okay, sir. Sir, another one quick question, sir. Is it true that if we leave the if we put the needle and push the dye, and if it gets delayed, the needle gets blocked by the dye?
Needle do not get blocked by the dye. It is not that thick.
No, needle is not blocked, but it is difficult to push.
Difficult
because
to
it is
push.
thick, viscous. It is difficult to push, but it will not be blocked.
Okay, sir. Okay. Thank you, sir.
Okay, so let us
Okay.
finish for today. Any other question, Kanchan, in the chat box?
No, sir. They were asking about the channel name. So that
Thank
is
you,
Dardia
sir.
Brain Clinic. Okay.
Okay,
And
Dr. Mohammed Sulam has already shared it.
yes, so and boss, you can tell tomorrow, like next class, again we are
No,
gonna
okay,
have
one
Kahoot.
important announcement. One important announcement is already I have shared also that in this Sunday, the exactly today's module with SI and everything is there in the Baroda Orthopedic Association and Baroda Pain Clinic has a joint program on this Sunday, 27th June, from 10 p.m. 10 a.m. to 10 a.m. to 12:30 p.m. So the same similar kind of lectures. So it will be having a recapitulations, and also you can ask the questions. Some other things like discography and SI joint interventions will also be demonstrated and so on. So please, all of you join that. Already we have shared. I have shared the the flyer with your group, Telegram group, and you can click there and you can join on Sunday.
And next Kahoot.
Another question is where to get across the recorded video. So join the Telegram channel. It is there. Okay, everything is there in the Telegram channel.
One question, please, sir.
Yes.
Sir, should we know about the next class topic? What will be the next class?
It is there in the website and it is shared before also in the Telegram channel. Like today, 2-3 days back, I shared the today's topic.
Okay, thank you, sir.
Okay.
You just keep an eye on the Telegram channel and your email ID. So everything will be shared. Please note
Nowadays,
that.
we are not sharing much to the email ID, except when it is shared in the email ID, that joining link, I have put that in Telegram as well. So follow the Telegram first and email ID and nothing more.
So all the instruction, everything is there. You just follow those Telegram channel instructions.
And next Kahoot will be on today's class, isn't it? Boss?
Yes.
Yes. Get ready for the today's class, and it will be shared on the it will be questions will be there, multiple choice questions next day before starting.
Okay. So
okay, so let us end today.
Good night, everyone. Take care. See you next time.
Good night. Good night.